It's my pleasure at this time to introduce one of my partners, Aleks Mladenovic. Aleks started his career working in both the United States and Canada on behalf of physicians and in medical negligence matters. Aleks is a partner at our firm. I'm delighted to have him as one of our partners. And he has a particular focus at the present time in the area of medical malpractice litigation. Aleks has tried cases at all levels of courts. He's been named one of the leading medical malpractice lawyers in Canada by Law Day, which is a North American resource source for the legal profession. He's also been named a Lexpert expert as a leading practitioner in the field. He's authored numerous articles on litigation and the importance of the litigation process and safety in medical care. And the only lapse in judgment that I've ever known Aleks to share is that he likes Novak Djokovic rather than Roger Federer. So anyway, I'd like to introduce my partner, Aleks Mladenovic.
Thank you. I'm still recovering from Novak's loss on Monday. But I don't recall seeing Roger Federer anywhere in the quarterfinals or the semifinals anyway. Well, thank you and welcome back. I hope you enjoyed your lunch. We're continuing with our theme of from home to hospital, and we have a great panel assembled for you today to discuss new issues surrounding occupational therapy, physiotherapy, and speech-language pathology. And each of the panel members is going to give a presentation, and then we'll have hopefully some time for some questions. I'll try to ask a few, and you might have some yourself. So without further ado, I want to introduce the panel. The first person that you're going to hear from is Elizabeth Farquharson. She is a physiotherapist, and she's been working as a physiotherapist at Sunnybrook since 1991 in acute care trauma. She has also, in the last 5 years, had the role of patient care coordinator in the trauma service. And she has, in that capacity, a great deal of exposure and deals with patients with ABI. Next to Elizabeth is Debbie Hebert. Debbie is an associate professor at the University of Toronto. She focuses on occupational therapy. She works at the Toronto Rehab Institute. And she deals, again, in a clinical setting with patients who have acquired brain injury and traumatic brain injury. In addition to her clinical practice, Debbie has extensive experience with continuing education, and she sits as the chair of the Continuing Professional Development Committee at the University of Toronto. And last but not least, Jeanette Podolsky. Jeanette is a speech-language pathologist with more than 30 years of experience in the field. She has established a full-time private practice focusing on treatment of patients with acquired brain injury. And she has also established the Speech Therapy Centers of Canada. And so these three eminently qualified people will talk to you about new ideas in their respective fields. And we'll start with Elizabeth from the standpoint of physiotherapy.
Thanks very much. And right now I'm experiencing considerable symptoms of an anxiety disorder and wondering if the good doctor previous could give me any tips. Anyway, thanks very much for inviting me to speak today. First of all, technologically, I have to work out how to operate this, which is pretty easy. So I've been given a task of giving you a synopsis of physiotherapy in 10 minutes in acute care. That is some task, but I will do my best. So I'm going to cover 4 areas in my discussion. And some of them do not bear relevance to physio, but they are new topics in the treatment of TBI at Sunnybrook. So the first one is the TBI protocol that we're following right now in our ICU. The second one is our early mobility initiative that's happening again in ICU. And the third topic is our continued emphasis on mobility once the patient reaches the trauma floor, using our least restraint policy And then the third, and probably the most important, is, sorry, how do I go back? Doesn't, okay. Is our truly collaborative team approach to the trauma patient on our floor. It is a multifactorial team, and we as physios cannot operate without that. So I'm just going to gloss over the new ideas in TBI. And basically what we've decided in our critical care unit is to have an ICU within an ICU. The development of the neurocritical care team has been spearheaded by Drs. Martin Chapman and by Dr. Fan in collaboration with Toronto Western and St. Mike's. And the improved outcomes in TBI using the specialized neurocritical care teams have shown an improved consistency in goal setting, attention to detail, and again, improved collaboration between specialities. So just for the purpose of our categorizing our severe TBI patient, their definition is the fact that somebody comes in with a GCS 8 or less and an abnormal CT, or a normal CT but at least two of the following. And if I can just, that the age is more than 40. Sorry, I'm not sure if this is coming up on your slides. No. Age is more than 40, that they have a GCS 3, or and a systolic blood pressure of less than 90 at any stage between incident and coming into critical care. So the management consists then of a very specific protocol that's followed, and it pays attention to all these things here. So the head of bed, the ICP, the nutrition, all those things are taken into account. And again, you can see that multifactorial development of the team in moderating all of that. So really, our severe TBIs come into the critical care unit and they follow this protocol very closely, and the outcomes have been shown to be improved by the service following. So next, mobility in the ICU. So really, only about 5 years ago, our patients came in, especially, well, most of them in critical care, but specifically the TBI. They would be intubated and ventilated. They would be confined to bed for a long period of time, probably restrained, definitely sedated. And so research has shown, not specific to TBI, that the interruption of the sedation and PT and OT in the earliest critical stages of their patient's admission have resulted in much, much better functional outcomes at discharge and a reduction in delirium. Okay, so our patients are given a vacation sedation every day, except for the ones that are on the TBI protocol, which they stay on that for 48 hours. So providing there's no other medical contraindications, PT gets involved. The patient starts active assisted exercises, functional mobility such as rolling in bed, sitting, standing, and this would not have been seen 5 years ago. So here's a patient, a TBI patient actually, ventilated, intubated, and up on his feet, ambulating with a high-wheeled walker. Closely monitored situation, that's our RT on our left and one of our physios on the right. And so they get to the floor in a much better condition than they ever did before. So thirdly now, mobility in the trauma ward. We continue the emphasis on functional mobility. Our PTs, OTs, and again, the whole team effort, okay? We treat along the Ranchas-Lossamiga scale. So if you think, I'm sure everyone's familiar with that, but 1 being comatose patient, 8 being a patient functioning such as you and I in the community. Our most difficult or challenging stage is a stage 4. And it's our job in acute care, really, to progress the patient from their stage 4 to a stage 5 so that they can then go to rehab, active rehab. So they need to be at a stage 5 without an observer. We manage the acute agitation by using observers. So we do not restrain. The observers are educated by our PTs, OTs, and our nursing staff regarding each patient. And they are asked to be included in the functional gains of the patient. So if they're able to, they can assist a patient to the bathroom. And really mobilize if they can, and again, promotion a lot of functional activity. Obviously, our PTs and OTs continue to treat, and we use the neurodevelopmental techniques and Bobath to really use the neuroplasticity at this stage. Okay, and onto that is our team approach to TBI recovery. The treatment of the TBI patient on the trauma unit at Sunnybrook, our PTs and OTs operate in a collaborative model. Being in acute care, we're not staffed for rehab. We have 2 PTs for a 36-bedded unit. We have 1.6 OTs for our 36-bedded unit, and they also cover our critical cares. So operating with a co-treatment not only gives us an extra pair of hands, but our patients at this stage are often unable to attend to a full treatment session. So we maximize the windows of opportunity that we have in order to assess and treat. And by using PT and OT, they both glean the information that they need appropriately. Again, as I've said, we try and progress the patients through their stage 4. And this needs everybody's cooperation, not only PT, OT, but the nursing staff. We try and find common goals for the patient. They have to be flexible. They have to be precise and to the moment. We use our volunteers that we have on the floor to increase mobility. Our ward support staff are involved. I can give you a little scenario. We had quite a head-injured young lady recently who actually was very mobile, but extremely cognitively impaired. She had no memory and no insight into her condition. So our support work, our PSP, or one of our support staff, used to take her off to go and get charts, to go and collect linen. So she was continually mobile. It decreased her agitation, gave her some sense of purpose, because we have no recreational programs in the acute stage. And it's very boring and very difficult for the patients as they wait. So there are risks involved with progressing our patients. We do have to take our observers off sometime. And again, a really good team approach to withdrawing the observers, placing a patient near the nurse's station so they can be observed by everyone. I'll give you a little analogy here. When I was in my dim and distant youth, I lived in the tropics, and we lived in a country who the lakes were not as nice as they are here. Number one, there's crocodiles. Number two, there was a nasty parasite lurking around the edge. So my father used to take us out in the boat, and in order that we could swim, he used to do a circle around with the boat. We used to jump out, avoid the crocodiles, and then jump back in. So our floor is totally chaotic sometimes, right? It's loud. We have to allow people to express their frustrations, and we have to keep them safe, right? We have to keep the crocodiles at bay as best as we can. And we do this not only with PT, OT, but our entire floor. even our ward clerk actually supports patients, getting them drinks, trying to provide for their needs as and when they happen. So the common goals between the nursing and the rehabilitation team are really, really important. Again, pharmacy, we do use pharmaceutical management, but we try and keep it to a minimum. So as the analogy goes, it takes a whole village to raise a child. So it takes an entire ward of dedicated staff and family, and a lot of education of them, the staff and family, to get a patient to progress beyond acute care. Now I'm going to hand the podium over to the next stage, which is rehab.
Well, again, thank you very much for inviting me to speak to you. I've been asked to provide you with some updates of approaches to working with people with cognitive dysfunction from an OT perspective, with an emphasis on transition to community. And I'm speaking to you as an educator in Toronto Rehab. My job is really to provide clinical consultation and also to help translate new areas of practice into the hospital environment. I'm also speaking to you a little bit wearing a bit of a researcher's cap from my involvement in a collaboration between Quebec and Ontario, looking at no less than transforming community integration. It's a collaborative led by Deirdre Dawson and Carolina Bottari. And so those are the perspectives I will be speaking to you from, and I'm going to highlight some of those, the work of some of that group. As I've only really, let's see if I can do this. Ooh. Oh, am I going backwards? That's what I'm doing. Green button, okay. It's not going. Oh, okay. Ah, there we are. Okay, sorry about that. So I'm going to talk to you about some selected topics. I'm going to talk to you about sort of the context we work in now in a rehab environment and how that affects some of the things and the changes that we make. I'm going to talk to you about some top-down approaches that have become more and more popular in occupational therapy, and I'll explain what that is in a minute. I'm going to talk to you about bottom-up approaches. I'm going to talk to you a little bit about the need for guideline development and a very good example of guideline development, and then some discussion about methods of delivery of intervention. So I want to first talk about the context for delivery. Certainly, we are seeing patients in shorter lengths of stay, and they're starting their therapies a little earlier. This is forcing us to take different approaches in terms of what we do in the clinic. So our treatment is often very occupation-based, teaching strategies, getting people ready to facilitate a return to home. In order to provide some of the rehabilitation of some of the impairment-based types of things that we do, we've been having to spend more time actually involving our support personnel, including rehab therapists and OTA PTAs. So this is a really, we're in a transition, I would say, right now, and we're still working on how that will happen. Another thing that's something that we all have known for many years now is that neuroplasticity is well appreciated. It's appreciated by our clients. It supports both a role for top-down and bottom-up approaches in treatment intervention. And many of our clients' families know about these and are wondering why people aren't getting a certain type of approach within the context. We have to really evaluate what's going to give us the biggest bang for the time that we have with our clients. We're also in an era of technology. We have all kinds of new mechanisms for providing delivery of intervention, and these are just beginning to be looked at in a very sophisticated fashion. We also have some new knowledge to think about. In a recent article by Diane Frasca, she talked about looking at those clients with TBI who don't do so well or have a cognitive decline after they've been discharged. And there's some mounting evidence that this is related to how much environmental enrichment clients have. Miller and Green have actually looked at this from a neurophysiological kind of perspective, and they've found that people have changes in their hippocampus that correlate to a decline, and this is related to how much stimulation they had 5 months post their injury. So that makes us think about how we're going to plan for these earlier discharges and make sure the right kinds of things are in place. So given that, let's start to think about the top-down approaches. The features of top-down approaches are approaches that work with people at the occupation base or the activity base, are that they do address occupational performance, and it's one that's valued by the person. The person that's involved in this is critical in devising the approach to treatment. There is a potential for transfer to other tasks. And we used to think that if you train somebody on one task, it won't transfer to others. We're now finding that that is actually dependent on how you train people to do things. And usually that involves a metacognitive type of approach. So promoting and developing an awareness and control over one's behavior. Some sample interventions are goal management training, and Baycrest has been doing a lot of treatment around that. The other types of, a newer one for occupational therapy is the cognitive orientation to performance, or co-op. This is, again, is, this part of it is led by Deirdre Dawson. It's based on an approach used with children, and it incorporates a metacognitive approach, verbal self-instruction. It's contextualized in the environment that the person is in, and the goals are meaningful to the client. So how does this work? Well, basically it starts by the client selecting their own goals. The intervention actually arises from an observation of what the person is doing, and looking at what the performance problems are. And then the treatment is really to try and bridge the gap by providing specific task strategies, and also a global strategy of setting a goal to try something new, planning to do it, doing it, and checking it. The therapist actually guides the patient to figure this out for themselves. They don't say, it looks like you've missed all these things when you went up to the counter to order this. I think you should write it down. They ask them to think about processes that they might do. It's a strategy that actually works really well when the context of the person themselves supports it. So if caregivers support it, it works quite well. The only published research right now is on a 3-case study situation, and it had a lot of success. They found that 7 out of the 9 goals that were identified by the client using the COPM were actually improved, and the client had satisfaction with this. And the tasks that they didn't train directly using this technique also benefited. So there is a transfer of training to help people to learn in this methodical fashion. There are many other top-down approaches, and I'm not going to review them right now, but this is a sort of a good model of working in this new environment and helping people to learn. So I want to talk to you a little bit about bottom-up approaches. We certainly have evidence for effectiveness of bottom-up approaches. Cicerone has done a lot of review of randomized control trials, and spoken to a lot of evidence for different types of techniques that will help improve attention, executive function, perspective memory, a number of things. A recent review by Van Houten suggested, yes, this is all very true. There are now 95 studies that are reviewed, but we are not really giving people enough information about how to do these tasks. Now, the American Congress of Rehabilitation published a manual for training, but it also comes with a training course to look at these kinds of things. And how to deliver them in an effective fashion. So I think we are starting to move along in that direction. Now, again, I say, while we know these things work, they usually take many, many more trials and a lot of intensity of treatment. And we are now finding that this is necessitating us to shift how we actually do it. So we can give the person the kind of intensity they need. I wanted to speak about some bottom-up approaches from a technology-based perspective. So we have a lot of new versatile hardware. We have PDAs and tablets and GPS in our tablets. And if you watch Breaking Bad, that's not such a good thing. If you have a GPS, you get in trouble, as according to last week's episode. So, we've just started to really research this. And in an article by DeJude, they looked at PDAs, and they used PDAs for memory training, and they used a program called PEAT. I won't go into it. But they compared that to paper and pencil methodologies and really found no difference. So what does that mean? It means that it's as good. I think the joy of being able to use your PDA is that it looks the same as everybody else has. And if you are able to learn the applications, it works very well. PDAs can be used to do wayfinding internally. Chang just presented a technology that helps you to get around an internal environment using radio frequency ID tags in different parts of the room. And when you get to a part of a room and you're trying to know whether you need to go down the hall or left or right, you can read the ID tag, and if it knows the direction you're going into, it will show you a picture with an arrow. So there are ways that we're going to be thinking about that we haven't even begun to think about. We have a lot of apps, which I'll talk about in a minute, for ABI. Virtual reality. Now, although virtual reality is virtual and it's not really real looking completely, the work that they've done with virtual reality has shown improvements on things like selecting a bus and getting on and off. So things that you wouldn't necessarily do without in a real environment the person wouldn't do it on their own. But it's a safe way to sort of try it, and that's what it affords, is that opportunity. We're developing a driving simulator that's very fancy at the Toronto Rehab Institute, and I'm very lucky to be part of that. And it can simulate rain and darkness and glare, all those things that you might not be able to recreate on a one-time driving test. But you can give people the experience of doing that and seeing if it affects their driving. We use a lot of, we're starting to use online cognitive approaches for remediation. Berquist has been doing this for a little while now, looking at some memory remediation. My colleague, Edith Ng, just finished her master's degree, and she was looking at using co-op through Skype with clients. So an outreach opportunity with clients that may not be able to come into the facility. And speaking of apps, there's a lot of apps available for people with acquired brain injury. You can do anything from being able to locate where you are, take a pill, track your mood. There's many, many varieties, and I put this on here if anybody wants that list. I know it's not in your handout, but I wanted to bring it to your attention. I wanted to talk to you a little bit about guideline development. Some of the things that we need to negotiate and consider and work with our clients with are hard to do. Return to work is one of those issues. And I wanted to highlight some work by Mariquita Sturgio, who just finished her PhD, and she's published an article, which I've included in your references, looking at guidelines for return to work. I just want to give you a sense of how rigorously they were done and how nice it is that we are marrying those research findings with best practice of clinicians in this kind of process. So she did a systematic review, she developed guidelines, she involved clinicians, and then she rewrote the guidelines, and then she did a pilot test with them, and now we're doing a pilot test actually on our own clinic in neurology in her private practice clinic upstairs. She nailed it down to some crucial events that are elaborated, and I would refer you to her publication to take a look at that. The pressures right now are forcing us to change our delivery models. A few years ago now, we moved to a block system, for instance, to deliver day hospital interventions for our clients, knowing that some people may be coming out quite early. They may still need some intervention types of therapies and some early rehab, but they aren't quite ready for driving and they aren't quite ready for return to work. So after an initial assessment and identity of goals, the person can choose to use their 3-month period of time and divide it into month blocks, however they want, over a year. I think the work looking at our clients who are returning to the community fairly early and knowing that enrichment is very important begs us to help them establish a routine and structure the environment to engage them in their daily activities so that they will not reach phases of depression too early, and they will be able to keep engaged and keep stimulated. I think the use of technology for outreach is tremendous, and we've talked about a couple examples. I know Jeanette's going to talk to you about another outreach example. And the other thing that we need to think about is perhaps looking now to training volunteers and support staff to deliver intervention in a different way. One of my colleagues on the collaborative, Helen Lefebvre, has been looking at training and has been training people in the community to work with people for a year that have been discharged home, and they commit 3 hours a week, and they help accompany people to doing the tasks that they might not initiate on their own. And at the 6-month period, she's found some good success with that so far. So I hope that has given you 1 or 2 ideas of some of the places we're going and some of the newer trends. And if you have any questions, I'm happy to answer them later. Thank you. Now turn it over to Jeanette.
Thank you, too, for inviting me here today. And my background as a speech-language pathologist is as a community-based speech-language pathologist, but I'm very well aware of the settings, such as the hospital setting and the CCSC role as far as speech-language pathology is concerned. So, in the beginning, when people are admitted to hospitals or they go to their doctor's office, communication issues may not be addressed immediately. There are many reasons for this. People in the hospital settings may have pain, mobility, and behavioral issues, and as we heard today, ESL issues as well. But the complex communication issues that we typically see following acquired brain injury may be invisible. They are absolutely there. And I'm not talking about the people who have the obvious speech disorders that we can all easily diagnose. Sometimes we may be aware that they're word-finding issues. That's very common. But we're not always aware in the beginning of the language functions, which involve the dynamic nature of communication. Communication issues become more obvious when moving from the patient to the person in the community. And communication issues affect not only the person with acquired brain injury, but the communication partners. And we need to think of communication as shared meaning, not just dealing with the person with the injury. So in fact, what I'm suggesting is that communication issues need to be addressed from day one. But we all know how clients, that we've spoken a lot today about rapid discharge, and that is a topic for another whole discussion. In fact, what I want us to think about speech-language pathologists is communication interventionists. And if we look at the incidence of speech-language disorders, and particularly cognitive communication disorders, Sheila MacDonald states they are as high as 80%. That depends on how we assess our clients. So looking for the complex issues is extremely important when you're looking at people's speech-language pathology assessments. And again, when you look at, I think, that absolutely brilliant Obaya impact report from 2012, 82% of ABI survivors have trouble with conversation in a group. I think we all know that, but the percentage rates are pretty high. 91% have trouble making decisions. We use language to help our client, to help us make decisions. So you can see how significant the amount of communication issues there are. The signature injury that we see following an acquired brain injury, and I think this is a very well-versed group, you're very familiar with this, is the cognitive communication issue. So if you look at your right, you'll see the cognitive issues, and on the left-hand side, the communication issues. It's where the two intersect. So in other words, when we're looking at that group conversation situation, it's how our clients have difficulty remembering the conversation in a group. That is a cognitive communication issue. And furthermore, when you look at the research, cognitive communication challenges interact to produce the most troubling obstacles to academic, social, and vocational success. And I have added safety. So I know this is something that occupational therapists, rehab support workers frequently assess. From a speech-language pathology point of view, I want to look at something like bullying, something that occurs very frequently amongst our teenagers. Just think of our teenagers in a situation with other students trying to bully them. They have difficulty with word finding, difficulty integrating what other people are saying, remember what other people are saying. So our clients who have communication issues are uniquely vulnerable. Sorry, I'm not moving ahead with this. Moving ahead, and assuming we have determined that our clients have got a cognitive communication issue, I am going to recommend a new treatment approach that's come out of the latest research. Of course, we all know that working one-on-one with our clients in a group is essential. But added to that, that's come out of the research, is training communication partners. This is equally as important, and in fact, the ideal is using both. So I'd like us to think about speech-language pathology and the treatment that we give our clients from a very, very broad perspective. So who are communication partners? Well, in fact, it's each and every one of us here in the room today. This is a very well-versed audience. Each and every one of us are very familiar with working with people and communicating with people with acquired brain injury. But the late Dr. Mark Ilvasacker also talks about communication partners as being everyday people. And my work and my background from the Phasia Institute when I first came to Canada involved me training volunteers and communication partners. And the power of volunteers to help our clients is enormous. The research shows that a good partner helps a person with an acquired brain injury get the message across. And so communication partner training must be built into every program. What I'm going to present today is just one guideline that's come out of the research. There are several. I chose this one because the work has been adapted by Dr. Leanne Tour, the speech-language pathologist who got a huge research grant in Australia. And it originally comes from the work from Aura Kagan at the Phasia Institute. And this particular guideline is called the Modified TBI Behavioral Guideline. They talk about acknowledging competence and revealing competence. What is important about this, it's a very well-researched scientific methodology. There is a rating scale associated with this. I haven't included it for today because I don't include it very often with my clients, but it is something that can be used. I am going to take just one aspect from acknowledging competence. There are many areas involved in communication partner training. So I'm just going to take a snapshot for the sake of time. So let's take the situation of teaching natural adult talk. Just imagine when our clients have a brain injury, their ability to communicate changes. So too does the ability of the communication partner. The feel and flow of natural conversation has changed. And so our communication partners change. So as a speech-language pathologist, I am in the home with the husband and the wife. The husband is the person who has had the motor vehicle accident and acquired brain injury. We are all sitting down together and watching a baseball game. The speech-language pathologist and the wife know the results of the game. But at the end of the session, they ask the husband who played and who won the game. That is a testing question. It is not a true question. A true question would be, what did you think of the game? Let's change the context. The night before the husband went to the game, we know nothing about it, and we ask him who played in the game and what was the score. Then it would be a true question. So what I'm demonstrating in this kind of guideline is how nuanced and specific it is to enable our clients to feel as if they have value, as if they are competent. So even though it seems like it's simple, and we as speech-language pathologists have always included partner training, but not in as scientific a way as what this research has shown us, it is very, very specific and very detailed. And I do have to add in the research, because it was done by with speech-language pathologists, is that they did find that speech-language pathologists ask a lot of testing questions. So think about yourselves testing your partner, your friend all the time, and not having equality in the conversation. There are more aspects, many more aspects under the guise of acknowledging competence, many things like taking appropriate conversational turns, all things that each and every one of you know about, but it's in the partner training that the significance occurs. Moving ahead to revealing competence. How do we help our clients get the message in? How do they understand what we're telling them? And how do they express what they need to? And some of that was discussed by Deborah today. But I'm going to take another example of giving the person time to process the information. One of the things that I've seen from my mild, moderate, and severe clients is auditory processing difficulties in just about every one of our clients. So let's say the husband, the same husband, and his wife are talking about us selling their house. You know, after an acquired brain injury, there are very important things that need to be discussed. Once again, the husband's processing of the information is very slow. The frustration and the anger that the wife experiences, that they both experience, that this message is not getting in, is enormous. So this is where the role of the speech pathologist is so important, is training the partner so that we know that the husband can access communication. We know that he has an inherent competence, but it's how to get to that competence that is so important. Think of yourself when you're having a conversation, how rapid the turns are. This is not occurring with many of our clients who have an acquired brain injury. There are many more aspects, again, and I've just included it in your handout so that you can see about revealing competence. But I want to move ahead to some of the other things that they found from the research. And something, again, that I think everybody knows, including friends. But it's including friends that have been trained by the speech-language pathologist to be a communication partner. The value of that was enormous. The research showed that sometimes they made a bigger difference than actual rehab professionals. The benefits of communication partner training. Leanne Tour states, training everyday communication partners by a speech-language pathologist is an important complementary treatment for people with traumatic brain injury and their families to facilitate and promote improved communication outcomes. This increases the ability to participate. So I think you know behind all of this is the WHO definition of impairment, disability, and increased participation, functionality. Furthermore, SLPs can train people to create an environment where the individual feels that he can express his wants, needs, opinions, and ideas. The research demonstrated that there's reduced psychosocial distress in family members, resulting in fewer demands on support services with this type of training. As I said before, the direct intervention and partner training is the ideal. And what is so significant to me, when there's rapid discharge of clients, fewer services, certainly in speech-language pathology, this is something that this is a method of service delivery that can be provided in underserviced areas as well as via the web. So we can be training large groups of rehab support workers, either via the web or directly, to assist with communication partner training. In conclusion, communication partner training is an essential part of a treatment program. Cooperation and enjoyment will increase. This in turn promotes the opportunity for community reintegration. Speech-language pathologists, through communication partner training, help create access to successful living. So just like the physiotherapists may provide a wheelchair, may provide a walker, we as speech-language pathologists assist everybody with communication partner training so they can have access to communication. Thank you.
We're almost over time right now, but I wanted to give you, the audience, a chance to ask questions. You've got a lot of information here from different areas. Please, anyone have any questions that they'd like to pose right now? Nobody? Okay. I'll just ask Elizabeth, in your experience in the acute setting, how important, or do you think it's necessary that there be more OT and PT in that acute setting to, as you put it, keep the crocodiles at bay?
That's a difficult question to answer. Things don't always work out the way the research shows it. Research shows that the earlier the intervention, especially in view of the neuroplasticity of the brain, is better. However, it is patient dependent. And I think we have to assess all of our patients very individually before we say yes or no. Some people can't tolerate more than 15 minutes at a time. Some people don't have the attention, the insight into their injury to be able to attend to a full rehab program. On the other hand, some people do, and they're waiting a couple of weeks, perhaps more sometimes, for an ABI bed. I think at that point we could say, yes, we could partner with, and it would be a good use of, say, some insurance money. But as I say, I think it has to be very, very individual. Families always want more. And it's a very difficult issue to deal with, to say, well, maybe at this point in time it's not appropriate. Maybe we could work together to find out when it is more appropriate. Because those funds have to last a long time.
I think all of you talked about recovery, both in the acute setting and the rehab setting, as a collaborative effort. Debbie, maybe you can talk to us about the members of the team that form that collaborative effort, and what are their background, what is their training from the rehab perspective?
Well, we're very lucky to have a very large interdisciplinary team in terms of our acquired brain injury group. So we have OT, PT, SLP, social work, we have dietitians involved, we have physician, and I'm going to miss people, I know. But the support staff, I think that I was emphasizing, were our rehab therapists and our OTA, PTAs. And the OTA, PTA has a specific type of trainings. Our rehab therapists can be kinesiologists, they can be from a psychology background, they can have a number of different backgrounds. So how we utilize that expertise is very, very different depending on what their skill sets are. Yes, that collaborative group is essential to getting anything done, and I must say that they have a very strong and wonderful team at our facilities. So.
And Jeanette, in speaking about collaboration, your thesis, the ultimate collaboration between your profession and the family members and the members of the extended community of the patient. Can you talk to us a little bit about how you would envision those services being delivered to what you describe as a person in the community?
Well, many ways. I've done it. Firstly, there's an education piece to understand what cognitive communication is with the family members. The new research is fantastic. Although they haven't got definite guidelines, typically what they're recommending is 6 weeks, 2 hours a week. I haven't done that yet. We've got to look at things like treatment plans, etc. But it's definitely incorporated into my therapy, not just at the end of a session doing family partner training, either through, depending on the family's, large groups. So I've done up to 30 people where I've had all the friends, rehab support workers, whole teams, for one session, and then a follow-up session, say 6 weeks later. The other way that it can be delivered is to a team of rehab support workers, particularly up north in rural areas. I find that that's very effective. And as I said in the beginning of my presentation, the power of volunteers and friends is huge to support so that we can maximize recovery, to support the whole rehab.
Thank you. We're out of time. Thank you very much. I thank the panel members for, that was very interesting to hear. Thank you very much. So.